this external auditory canal. So you have these waves that are now being propagated through the external auditory canal. So you have these sound waves, and now they go more medially, and now what is it abutting right here? Tympanic memory. So on a beautiful summer day, right when you're about, if you go to the infield in the Derby and you're having like a nice, you're having a nice mint julep or something. Have you ever thought about why we have a tympanic membrane? Has that ever crossed anyone's mind at the Derby? Probably not. But it does for me, because that's kind of the weird person I am, right? So the reason we have a tympanic membrane is that what we want to do is that we want to convert this sound energy into what type of energy? Any engineers here? When you have this vibratory motion of the ossicles, what type of energy is that? What's that? Mechanical energy, exactly right. So that's mechanical energy. So basically what we've done so far is you've heard me talking instantaneously, we're turning sound energy into mechanical energy, right? Now, what's the next energy transformation that happens in the temporal bone? We go from mechanical energy into what? Any idea? No, close. And I'll give you a hint.
Hydraulic.
Close, yeah. How does that happen? So what am I looking at right here?
Water.
It's a window. It's a window, but you're close. It's a window, right? And what is on the other side of the window? Now say it.
Water.
Water, exactly right.
The Ironian Sea.
Exactly right. And so when we have a window right here, this window is not, it's a square window, right? But in actuality, this stapes abuts a different type of window. And what's the morphology of that shape of that window? Oval window, exactly right. So basically, on the other side, this stapes sits in the oval window. And on the other side of that oval window is what? Water. Exactly right. So what ends up happening is that this vibratory motion now gets transferred into waves, right? So as the stapes goes back and forth and goes back and forth, you end up causing these waves on the other side. So this is an example here of that stapes, and on the other side of this oval window is that we have different types of water. So in a way you can look at it, what's salt water and fresh water, right? So just think about the salt water being the perilymph. And on the other side, the endolymph right here is the fresh water. So what happens is as this oval window beats back and forth, it creates these waves. And these waves go backwards and they go forwards. And these waves that are going backwards and forwards are predicated on two things. They're predicated on the frequency of your sound and the amplitude of your sound. So as I modulate my voice, if I talk really high or I talk really low, you can discriminate these things, because this is all the difference in the waves that are being created on the other side of this oval window. So this salt water, if you will, gets transmitted to this endolymph. And this endolymph is located in this cross-section of the cochlea. So this is a cross-section of the cochlea, and you have fluid here, which is the scala vestibuli. You have fluid here, which is the scala tympani. So this, if you will, is the salt water. And then you have a membrane right here, which is Reisner membrane, and this separates the salt water from the fresh water. And the fresh water is located in the scala media. Okay, are you with me so far? Good. Okay, now you have fluid that's now going backwards and forwards. Now, if I look at this diagram, we're taking our fluid, and now what are we doing with that fluid? All of a sudden, we are now creating that. What energy is that? Electrical energy. And where does that electrical energy end up going? The brain. The brain basically is one big circuit box. The brain, if you've ever gone to your lights have ever gone out and you've gone to your circuit breakers, the brain basically is the circuit breaker of your house, right? You have all the electrical energy being concentrated in that one area. So the question that I asked you, and I talk about it's magical, is that how does that fluid energy get converted to electrical energy? We learned about this in medical school. I know you may have learned about it in 3rd grade if you paid attention. There's a certain structure in our inner ear that allows the transmission of fluid energy into electrical energy. Now, anybody been to Los Angeles, or not to Los Angeles, to Las Vegas? You ever seen Hoover Dam? Yeah. What is Hoover Dam?
Big.
It's a big hydroelectric plant, right? You've got all this stuff that's is a dam, and then the water's allowed through, and it spins these turbines. And what does a turbine create? Is there anything in the inner ear that acts as a hydroelectric plant? It's an organ, which is called the organ of Corti. So the organ of Corti is actually a hydroelectric plant. Because remember those waves that are kind of going back and forth in the scala vestibuli and the scala tympani? Those waves are transmitted to the scala tympani. The scala tympani has those same waves. And the scala tympani ends up moving these hair cells. And as these hair cells move, they end up activating this organ of Corti. It goes to the spiral ganglion. And it's these spiral ganglions that now go and create the vestibulocochlear nerve. So when I talk about the magic of hearing, all of this going from sound energy to mechanical energy to fluid energy to going through a hydroelectric plant to creating electrical energy, then going through your brain and being processed, this all happens instantaneously. So I wanted to give you just number one, a big overview of what the temporal bone is and why I think it's one of the coolest structures there is. Okay, everybody with me on that? So the next thing that I want to do before we kind of launch into this is now we're going to take a blown up image here. And what am I looking at right here, by the way? Let me see if I can get this to middle ear.
Middle ear.
Yeah, we're looking at the middle ear, exactly right. So what I want to do, hopefully this will work. Yeah, hopefully we're looking at the middle ear cavity. So the middle ear cavity is divided into 3 areas. So this is the external auditory canal. And if I draw a line here, is anybody red-green colorblind? Here, I should have asked that. No? Yeah, sometimes if I show red, you can't see it. So I've learned over time to ask that. No. Okay. So if I draw a line here at the external auditory canal, there's a margin here, and then if I take the bottom line of the external auditory canal and I cross it over, there's another line here. So the middle ear cavity is divided up into what? Into 3 different areas. Exactly. Exactly. So so think of the epitympanum as a house. So when you walk into the first floor of your house, you're sort of in the middle of the house, right? So that's why we will call this area right here the mesotympanum, or the middle portion of the house, right? Now, what's located at the top of your house, the very, very top? It's the attic, right? You okay, my brother? Yeah. He's astonished. I've made him choke. This is amazing. The amazingness of this whole thing, right?
None of us know how to run a car.
We're definitely pushing out to the hallway.
So what do you call the top of the house? The top of the house is the attic. And the attic can sometimes be known as what? The epitympanum, right? And then what do you call the basement of the house? The basement is below everything, so we call that the, where's my little arrow here? We call that the hypotympanum. It's I'm a hard time seeing it there. We can call that the hypotympanum, right? Okay. So you've got the tympanic membrane, you've got the middle ear cavity, and then you have these ossicles, right? Now, the reason I'm going through this is that when I was a resident, I knew nothing about the temporal bone. Zero. So I know when I went into my oral boards, I said a Hindu prayer, hopefully not asking anything about the temporal bone. And I said if they showed me anything weird, I would just say Mondini malformation and go to the next case. If there was something that would look weird, I'd say Mondini. If there's a soft tissue mass, I say Cholesteatoma, and then just show me a stroke or something like that, and I'd be all right. But after I got to my fellowship, I realized, the biggest challenge that I have with the temporal bone is getting oriented. Because when I look at the temporal bone, sometimes it's just overwhelming. I'm like, I don't even know where to start. So at least the way that I learned it is the following, is that what I try to do is that if I'm doing cross-sectional imaging, we're looking at images that look like this, right? So this is the malleus, right? This is called the head of the malleus. What's this part of the malleus called right here? Maneuvering the malleus. Perfect. So remember we just had a primer on engineering, right? So now we're going to have a primer on geometry, okay? If you look at the head of the malleus here, geometrically, what structure is that?
Circle.
It's actually a 3-dimensional
Sphere here.
sphere. Okay, geometry. If you did a cross-section of a sphere, what would you end up having? Now say it.
Circle.
Circle, right. Okay. Now, if you now took, what structure is this right here? Okay, geometrically, if you took the structure of this top part of the incus right here, what is that? What does that look like? A cone. A cone. And you guys are too young to remember this. On Saturday Night Live, when Saturday night was actually really funny, they used to have something called the cone heads. You ever seen that on YouTube or yeah, you guys are way too old. So anyway, we used to call them cone heads. So I remember the cone heads. So if you did a cross section of a cone, what structure do you end up getting?
Triangle.
So you guys all know this. What have I just formed right here? This is the famous what? That's the famous ice cream cone. Okay. So now, so when I was younger, I would call it an ice cream cone. Because I've gotten old and decrepit, it looks like a golf ball and a golf tee to me. So I now think of Tiger Woods and the golf ball and the golf tee, but we always call it the ice cream cone, right? So if you use that same approach, my point is that if you are way at the top of the epitympanum, you're going to see nothing, right? If you start coming down and you start seeing the ice cream cone, then what part of the temporal bone are you going to be located? Epitympanum. Now, this area right here was, what do we call this? We call this the manubrium of the malleus, right? And then this part of the incus right here was what? The long process of the incus. If you took a cross-sectional imaging right here through the manubrium of the malleus and the long process of the incus, what are you going to see? Two what? You said it. Say it again. That's a 2-dot level. Okay. That's a 2-dot level. Now, if you took a cross-sectional imaging through the hypotympanum, what are you going to see? Nothing. So there you go. By knowing nothing, you already know a third of the temporal bone, right? Because there's nothing there. Right? All right, so you understand the landmarks. So these are the anatomic landmarks. So when I was a resident, and I can tell you this, and when I was a fellow, actually, what ends up happening is that this was my epiphany. My light bulb went on. I realized the first thing that I've got to do is figure out where I am on cross-sectional imaging. Once I understand where I'm on cross-sectional imaging, then I can kind of work my way down. So for those of you that have the proclivity, especially the fellows and any of you residents that want to go into neuro, I would encourage you is just for the next 2 weeks, just before you go to bed, just review the temporal bone anatomy for 5 minutes, 5 to 10 minutes. And if you do it for 2 weeks, you will never forget it. I guarantee you, okay? So if you're interested, that's what you do. So let's go ahead and begin our journey on the temporal bone, okay? So who wants to take the first one? We're going to talk right at the top of the temporal bone. So this is going to be our landmark right here, so you know where you are, okay? So who wants to take the first one? What level are we at? Any fourth years? Okay.
I'll take it.
Yeah. What level? We're just going to, what we're going to do now is we're just going to step through the anatomy. We're just going to go over the cross-sectional axial anatomy. When you're done, you will know all of this anatomy, okay? So what level are we at here?
So we're at the epitympanum,
Good. What is this right here?
petrous temporal
Good.
bone.
What are we located right here?
Probably the IAC,
Perfect. What are we located right here?
the mastoid air
Good.
cells,
What's over here?
the brain,
Yeah, what part of the brain? Perfect, yeah.
temporal lobe,
Temporal, perfect, yeah. What's back here?
the cerebellum,
Perfect, right. And now what do you think these guys are right here? You got something here and you got something here and you got something here.
that's a semicircular
Good.
canal,
And which one, what do you call the semicircular canal that's posterior?
posterior semicircular canal,
And what do you call this semicircular canal that's going way up top?
superior
That's
semicircular
exactly
canal.
right. See how easy temporal bone is? Let's go to the next one. Okay, all right. Who's next? All right, carry on. What are we looking at right here?
Petrous apex,
Right, we're right here.
internal auditory canal.
Good. What is this right here?
Is that the vestibule?
I ask the questions. No, I'm kidding. What is that? You're exactly right. That's the vestibule, right? Now, which semicircular canal is this one? And then which semicircular canal is going to be this one?
I'm wondering if the one that's more anterior is going to be the anterior semicircular.
You're close. Well, let's start with the one that's posterior. What do you call it? What do you think this one is?
Superior or posterior semicircular?
Posterior semicircular. And which one do you think is this one right here that's sort of horizontally shaped and heading laterally?
Lateral semicircular.
That's the lateral semicircular canal. What are we looking at right here?
Mastoid air cells.
Exactly right. Now, what I want to do is, what do you think this is here? And it goes to here. And then on the next image, it's coming here.
Canal for facial nerve.
That's the facial nerve. It's the facial nerve. Now, the facial nerve, here's the facial nerve, okay? So we know that when we look at the internal auditory canal, There are 4 nerves, but we're now going to concentrate on this facial nerve. So what do you call the part of the facial nerve that's located right here that runs in the internal auditory canal? Canaliculus. What do you call that portion of the facial nerve that runs in the bone right here?
That's the,
Tympanics.
What's that?
Tympanics?
what is the labyrinthine?
It's the labyrinthine segment. Yeah, that's close though. So now what ends up happening is that this facial nerve ends up coursing upon itself. What genu is that? I heard a lot of things.
Geniculate ganglion.
Okay, so we can tease that out because everyone's right. Okay, when I give a talk, everyone's right. Okay, so you've got this turn of the facial nerve is called the anterior genu, and then what's the ganglion associated with the facial nerve? That's the geniculate ganglion, exactly right. So the ganglion, remember, it's a special type of neural tissue, and for the fellows, what's the name of this nerve right here? What's that? Say it.
Speeded petrosal now?
Close, but you got that. Substitute the S with a G. It's a greater superficial petrosal nerve. That's okay. You don't have to know that. If you're a fellow, I expect you to know, but that's okay. So then you have this area right here, which is the canalicular segment. You have the labyrinthine segment. You have the anterior genu. Then you have this segment right here that runs in the middle ear cavity. Now, what do you call that segment? Tympanic segment. And then eventually, the facial nerve runs posterior, and then it drops down. What do you call this genu right here? Posterior genu, and then it drops down here, and this is called the mastoid. So can someone get the lights work real quick for me? Okay. So what I'm going to do, you seen the paperclip trick?
Up, I think. You want that up.
You ever seen a paperclip trick? Here's the paperclip trick. I think I gave it to you last year.
Yeah, I still have it.
You still have it?
Yeah.
All right. Well,
in my
where?
basement.
It's in my basement. It's in your basement. It's not under your pillow or anything like that? All right. So here's a paperclip trick, all right? So we know that the facial nerve exits the brainstem and eventually extends into the internal auditory canal. So what do we call that segment of the facial nerve? Let's just say this is my brainstem here, my finger. What do we call this segment of the facial nerve that goes from the brainstem that extends into the internal auditory canal? Cisternal segment. Then what happens is that the paperclip now turns this way. And now we have a segment that runs in the internal auditory canal. What do we call that segment? Canalicular segment. Then what happens is that we have that piece of the facial nerve that starts running through the bone right here. And what do we call that segment that, let me get that paperclip right. We'll just go, what's the segment right here that runs from the brainstem to the internal auditory canal? Cisternal. What's the portion that runs right here through the internal auditory canal? Canalicular. And what's the segment that runs through the bone right here? Labyrinthine. And then what happens to the facial nerve? Because it's heading anteriorly, right? So then what happens to it?
Posteriorly and laterally.
It takes a posterior turn. The reason this is called the anterior genu, and it confused me a lot, because it's the most anterior portion of that facial nerve. Okay, that's the anterior knee. So you've got the anterior genu here, right? Now what happens? It's running from anterior to posterior in the middle ear cavity. So what do we call this segment right here that runs in the middle ear cavity? Tympanic. Now, right now, when you're looking at this facial nerve, it's kind of like this, right? I don't want to poke myself in the ear, but we're sort of at this level, right? Where does the facial nerve have to end up eventually? And what gland does it end up being? Right. So which way does the facial nerve need to turn now? Inferior. So what do we call this genu that now turns down? That's the posterior genu. And then this portion of the facial nerve here is now called what? Mastoid, or the descending portion. Okay, so that's the paperclip trick. Okay, so you can actually now learn that this part right here was cisternal. Then we have canalicular. Then we have the labyrinthine segment. Then it turns on itself to form the anterior genu. Then we have the segment that runs in the middle ear, which is the, then it turns inferiorly, and then it descends, right? Right. So that's the segment, those are the segmental anatomy of the facial nerve. Anybody want this? Takers.
I won't take it. I'll take another one.
We have two.
Mine's better than yours.
So when we look at that, now what we can do is that we can go back to here, and if I said this part of the facial nerve is going to be what? We're all experts here. Canalicular. This is going to be the labyrinthine. This is going to be the. Good. What's the name of the ganglion here?
Good.
We go to the next one right here. This is going to be the tympanic segment, and then when the facial nerve now turns to go inferiorly, that's going to be the what genu?
Posterior.
Perfect. Exactly right. Got it? All right. Excellent. Excellent. Okay. Now we're going to go back to where we were before. So who's next? Fourth years?
Good.
Let's do it.
Sure.
Sounds like you're on Jeopardy when they say bring it. Watch Jeopardy. Bring it. All right. What level are we at?
Epitympanum.
That's perfect because this is the what?
I think it's
Whoa.
malleus, sorry.
Malleus. So, okay. So I'm glad you sort of said that because that's going to help us on coronal anatomy. So is the malleus or the incus more anterior?
Malleus.
Malleus is more anterior and the incus is more posterior. So what part of the malleus are we looking at right here?
The head.
Yeah, and this is the,
Incus.
right, and this is going to be the short process, right? So this is the famous what? This is the famous ice cream cone. So when you see the ice cream cone, that means we're at the what level here of the middle ear? We're at the epitympanum, right? So on this image right here, I want to make sure you know where we are. We're right there. So this is the epitympanum. Anybody know what this is called, right? Do you know the other name for the epitympanum? It starts with an A. It's like the top level of your house. It's called the attic, right? But, you know, in Latin, I think the T is substituted with the D. So we call it the space, that opening that goes from the attic to the mastoid ear cell. Does anybody know the name of this? It's a three word. That's the additus ad antrum. So it's additus, not atticus. If I had to rename it, I would call it additus ad antrum, not atticus. But anyway, that's additus ad antrum. And here's our mastoid ear cell. Good. What were you looking at right here?
This is vestibule.
Yep, exactly. What's right here?
The mastoid or the petrosal bones.
Petrus bone.
Yeah.
Petrus, yeah. Just say Petrus apex or Petrus bone. And then anybody, there's a little septum that runs right here that starts with a K. Anybody heard of that? That's Kerner septum. Excellent. This is what Kerner septum is. Perfect. What are we looking at right here, by the way? This is the what?
Sinus.
Which sinus is that?
Transverse sinus.
Yeah, it's sort of the junction between the transverse and sigmoid. And the reason why I mention that particular, especially for the fellows, one of the reasons we do a lot of temporal bone imaging is for pulsatile tinnitus. And so one thing, and I don't know how accurate it is, but I know a couple of the otologists that I work with are super persnickety. And someone that has pulsatile tinnitus, I always pay attention to that little bone thickening. Because sometimes that bone thickening gets dehiscence, and if you read the otology literature, some otologists will actually go in there and do a resurfacing procedure, especially the patients have objective tinnitus. So for the fellows in the audience, when you are looking at the mastoid ear cells, just have a look right there, especially if it's ipsilateral to the side of the symptoms. All right, who's next?
I can go.
What year are you?
I'm 4.
You're doing ER, right?
Yeah,
You still want to take it?
I'll take it.
Okay.
Sure.
All right. Good. What level are we at?
This is still the epitympanum.
Right, exactly right. So this is the, real quick,
The malleus,
good, here,
and that's the incus.
good. What's back here?
That's the mastoid ear cells.
What's here?
That is the internal auditory
Good.
canal.
What's here?
That's the Petrus apex.
Perfect. What's here?
That is the vestibula.
Good. What's vestibule?
That's the cochlea.
Good. And what do we call this little bony strut in the middle of the cochlea?
That's not the sputum. That's on the other side. So that is.
I mentioned in the last talk, and I know you were there, and I know you're.
No, I was there.
And it starts. You want a hint?
Yeah.
M.
Huh.
Huh.
No. Is
Yes.
it? Is it? Oh, okay.
That's the modiolus.
Yeah. You know, I only recognize it now when it's dissected out and beautiful.
Oh, okay. All right. Or it can be called the modiolus if you want.
Yeah,
I
okay.
call it the. I'm from the south too, so I call it modiolus.
Okay.
If I was someone fancy, I'd call it modiolus, but it's the
Yeah.
modiolus. So what do you call? And for anyone can take this. What do you call this opening right here?
To the round window?
No, no, no. This is right at the base of the cochlea. And remember, this is the internal auditory canal.
Oh, yeah, yeah.
Yeah, the internal auditory canal, that something goes through the apex of the internal auditory canal and wraps around the modiolus. And we sort of talked about it because it kind of represents one of these nerves. So do you know what nerve runs through here?
The cochlear nerve?
It's the cochlear nerve. But how many nerves actually form that eighth nerve?
3.
Perfect. Do you remember that all 3 of them?
Vestibular,
Superior vestibular,
the inferior vestibular.
inferior vestibular, and
Yeah.
that's perfect. You're doing fabulous. Okay, wonderful. So this is the internal auditory canal. This little opening right here is called the cochlear canal or the cochlear nerve canal. The little bony strut right here is the modiolus, which is what the nerve wraps around. And then we have the apical, and then we have the middle turns of the cochlea.
Okay.
And just for grins, what is this?
That's the facial nerve.
Good. What segment of it?
That would be, I'm leaning towards mastoid, tympanic then?
There you go.
You leaned wrong. Lean the other way. That's fabulous. Perfect. Okay, who's next? Good job for an ER doc.
Yeah.
I can go.
Don't worry, I'm gonna have a resident prelim to me.
You know I love you. All right. Who's next?
I can go.
All right. All right, you ready?
Yeah.
All right, we'll do the easy stuff first, and then we'll go to that next level. So what I want to do is re-emphasize the stuff we just went over, then we'll add something. You get it now, what I'm trying to do, right? All right. What's this right here?
Teacher's apex.
What's located right here?
The mastoid ear cell.
Good. What's the opening right here? I didn't ask that. What's the opening right here between the IAC, which you already know, and the posterior fossa? What's that? Oh,
Acousticus.
perfect. Porus acousticus is exactly right. What's the opening right here at the base of the cochlea? What nerve runs through there?
Sounds like the
Cochlear nerve canal.
yeah, it's like the cochlear canal.
Yeah. Cochlear canal, cochlear nerve canal. Now, what's the bony structure right here?
The dialis.
Yeah, the modial. Yeah, yeah.
Modiolus medialis, that's exactly right. And there's the apical turn, there's a middle turn, and what structure is this right here?
That's the vestibule.
Perfect. Now, the vestibule, can I convince you this is very dense white, right? Can I convince you there's less dense white right here?
Yeah.
What do you think this is right here? What do you think this is right here? What do you think lives right here? And then what do you think this structure is right here?
Round window.
Not round. So this is the oval window, and then what structure is going to be right here that lives right on that apex?
Fistulae and fenestra.
What's it?
Fistulae and fenestra.
No. You're making it too hard. The oval window is here, but what ossicle lives right here?
Oh, stapes.
The stapes, exactly right. And what level are we at right here, by the way?
With the epitympanum.
Epitympanum, but we're sort of, what's happening in my ice cream cone? It's kind of melting, right?
Yeah. So maybe meso.
Good. We're going from the epitympanum. So I look over here on the left-hand side, we're sort of right about there, right? Because we don't see the ice cream cone, but we're getting to what level are we getting to right now? We're going from the ice cream level to the what level?
I mean, we're getting to the incus and stapes, right?
Well, not the incus stapes, it's not an ice cream cone. What are the, if we did geometry, we did a cross section.
Triangle.
The dots.
The
That's
dots.
the dot level, yeah. Yeah, you got the 2 dot level. So remember, the ice cream cone is the epitympanum, and the 2 dot level is at the mesotympanum, right? So now we're heading into the mesotympanum. So this is the vestibule. This right here is going to be the oval window. And then what do you think this is right here that's now not going horizontally, but heading inferiorly?
I think it's still the facial nerve.
Facial nerve, exactly right. So where's my fellows here? Ready? I could ask you this, if you may know it. What do you call this structure right here that looks like a pyramid? It's the pyramidal eminence. And then what do you call this little defect right here that's just below the facial nerve, behind the facial nerve? That's called a sinus tympani. So for the residents, don't worry about that. For the fellows, here's the mastoid ear cell. We're going from the epitympanum to the mesotympanum, right? Because the 2 dots. This is the vestibule. Internal auditory canal, cochlear canal, modiolus, cochlea, right? With me? And for the fellows, this area that's dropping inferiorly is the descending portion of the facial nerve. This little bony strut is the pyramidal eminence, and that's a sinus tympanum. Got it for the fellows? All right, who's next?
I'll take it.
Oh, everyone's volunteering. This is so cool.
So it looks like we're more at the level now of the mesotympanum.
Why?
You can see the dots of the long process and then
Which one's anterior?
the malleus.
Perfect. And what do you call that portion of the malleus?
I think that's the manubrium,
You're exactly right. And what part of the incus is this?
long process.
That's fabulous. What structure is right here?
That's the stapes,
And you were just below it, but what structure would be right?
the oval window,
Perfect. What's located here?
vestibule.
Perfect. What's right here?
I think that's the cochleus.
What part, we talked about the apical and the middle turn. What turn of the cochlea is going to be right here? Basal turn. Exactly right. Good. What's descending right here?
That's the facial nerve.
Now, does this look like a pyramid to you?
Yeah, well, it's
What
more
would you call that?
pyramidal eminence.
And then what's below here?
You just said it. It was the,
It starts with a sign. It starts with an S.
yeah.
Sinus, Latin for middle ear or whatever, tympani. Right. And then what's located right here?
Mastoid.
That's fabulous. Great job. Wonderful, wonderful. Okay, keep going. Who's next?
I can go next.
Love it. Everyone wants to do it. That's great. Okay, what level we at?
Still like mesotympanum.
Perfect. Let's looking at you right here.
Basal turn?
Basal turn, exactly right. That's exactly. Now, look real closely. So let's go over what we know. What's descending right here?
Facial nerve.
Good. What's this right here?
Pyramidal
Good.
eminence.
What area is right here?
Sinus tympani.
Perfect. What's right over here?
Mastoid.
Perfect. What's over here?
Petrus next.
Doing great. What turn of the cochlea is this one? You got 1, you got 2, and then you got 3. So what turn is this right here?
Apical turn.
Apical turn. Perfect. What's right here?
The middle turn.
And this is the
Basal turn.
perfect. Awesome. Now, what do you think? What window is going to be right here?
Round window?
Perfect. That's exactly right. So that's why we call it the round window niche. On the axial images, it looks like a little niche. And when we go to the coronal images, you'll see it. That's great. All right. Next. Now you're good. All right.
Ditto. Basal turn cochlea.
Yeah. What levels are we transitioning to right here in the middle of your
We're
cavity?
getting close to that hypotympanum.
Right, exactly right, because we're starting to lose the dots, right? That's exactly right. So here's the mastoid air cell here, here's the petrous bone here. What do you think this is here?
Oh, carotid?
Good, good, excellent, fabulous. Right here?
That's the external acoustic canal.
So that's fine. What's located right here?
Oh, yeah, that's going to be our facial nerve
Good.
going down.
Yeah, what's right here?
That's the pyramidal eminence.
Right here?
That's the sinus tympani.
Outstanding. Perfect, perfect, perfect. Yes. See, isn't temporal, but you guys are getting the temporal bone, right? You with me, right?
See how it is in a couple of days, that's the thing.
It's going to, we're recording these now. Actually, I think I talked to Dr. Hadi. We're recording these right now, so hopefully we'll get the recording. You guys can always refer to it. I do have a YouTube channel where we have an older version of this, but hopefully we'll have the new ones and you guys can hear yourself on them. And I can make fun of everyone. There we go. Who's next? Hey.
Jordan wants to go.
No, I was a little tentative there, but she raised her hand.
Nana wants to do it.
She didn't really raise her hand. She kind of
No,
flicked
she was
her.
telling me earlier she wants to go.
She loves temporal bone.
I think she flicked me off, actually. I think that's what
It's possible, but.
All right, where are we then? We're not in Louisville, but where are we right now? Where are we transitioning to?
To the region of the hypotympanum.
Exactly right. You can talk a little bit loud. I'm very deaf.
His ossicles are
That's
working.
hard, but come on.
Okay, where are we right here? Perfect, exactly right. Where are we right here? Right here?
In the carotid,
Perfect, right here?
external auditory canal,
Good. Where are we right here?
mastoids,
Good. What's the little defect right here?
sinus tympan.
Good. What do you think this is going to turn out to be? If this is the carotid, what do you think this is going to turn out to be?
I can't even hear you now.
Jugular.
Jugular, I heard.
I think she said it in Hindi, but she's right. That's the jugular bulb. That's exactly right. That's perfect. So there's a point that I want to make here is that which one is more anterior, the carotid or the cochlea? Excuse me, the carotid or the jugular bulb?
The answer's the same.
Yeah, exactly. And then when we look at the axials, which one is more anterior? Is this the malleus or the incus more anterior? The malleus is more anterior. Okay, so the reason why I mentioned that is that you guys are doing so well. We have about 15 minutes left. I want to just go over the coronal anatomy. Okay. I emphasize one thing, as you've seen, there was a constant theme, is that when you look, so is everyone comfortable with the axial images? Yeah? Cool. Thumbs up? Okay. Now, coronal imaging, again, it's all about orientation. And you sort of heard me going through this, and I said, okay, which one's more anterior, cochlear or carotid? Oh, which one's more anterior, incus or malleus? Which one's more anterior, carotid or jugular bone?
Without contrast come out.
God, is that you?
Hey, Dr. Hottie.
God has spoken, and he's Dr. Hottie. I've been searching for God my whole life. So anyway, so
calling me out?
Okay. Yeah, Dr. Hadi, you're.
We can hear you,
We
Dr.
can
Hall.
I hear you.
Take.
Okay, sorry, my bad. I apologize.
All right. So anyway, so what structure are we looking at right here? Everyone can figure this out. What is that? Cochlea. Good. If this is the cochlea, what vessel is this going to be? Carotid. This is cochlea. What vessel is this going to be? Vessel? No, sorry. What ossicle? I'm doing. What ossicle is that going to be? Malleus, exactly right. What structure are we looking at right here?
External canal.
What are we looking at right?
Sputum.
Famous.
The sputum.
That's the famous sputum, exactly right. Now, if I go a little bit more posterior, sorry about these reformats. I know I've got better ones somewhere, but what are we looking at right here? I didn't think I was going to show these, but what are we looking at right here?
Vestibule.
Looks like a rabbit.
The vestibule.
That's the vestibule, exactly right. So when I see the vestibule, I kind of think of it as a rabbit. So I have this looks like one rabbit ear here. This is the other rabbit ear here. There's the mouth of the rabbit right here. So anyway, so what window is located right here? What's that? Oval window, exactly right. And if this was the vestibule here, then what window is this going to be? I have to get better coronals. I didn't think I was going to show these, so I didn't redo them. But that's a round window. So which window is here?
Wow.
And then which window is here? And then which vessel is going to be located right here?
Oh, is that jugular?
Just jugular. And how do you know it's jugular? Because it's at the level of the vestibule. So what I want you to remember is that's where the orientation comes in. So remember, what did I say? Cochlea is anterior, malleus is anterior, and carotid is anterior. So when I'm looking at these, and I do the same thing myself, if I see the cochlea, then I know I've got to be close to the malleus, right? And I have to be close to the carotid artery. But all of a sudden, if I just show you this image right here, and I show here's the vestibule, and you see this ossicle right here, what ossicle do you think that's going to be? Why? Because the incus is here, exactly right. And then what vessel is going to be right below this?
Jugular.
Does that make sense to you guys? Yes. Yeah, so I can go back and I'll just show this. I didn't really show this one, but I'll just show this one right here. So when you're looking at this complex anatomy, right, now knowing what you know, what vessel is here? What vessel is here? Jugular. That's exactly right. Make sense?
Cool. Yeah.
And then what we'll do is we will go to this. Okay. So I know you guys are getting ready for your boards, right? So what I want to do is go over two things real quickly, all right? And we got 10 minutes, right? And that's cholesteatoma. So everyone's heard about cholesteatomas, right? So there are two types of cholesteatomas. Anybody know the two types of cholesteatomas?
Congenital.
Okay, so someone tell me about congenital cholesteatomas.
It can be anywhere.
It can be anywhere. Fair enough.
Most commonly found in the adjacent to the cochlear promontory.
Okay. Keep going, you're doing good. What's the other name for a congenital cholesteatoma? It starts with an E.
Epidermoid.
Good. Are congenital cholesteatomas, are they found typically in adults or kids?
Congenital kids?
Why not kids?
Kids. Correct. Correct. Are they typically associated with children that have had recurrent middle ear infections? Yes or no?
Congenital, no.
Congenital, no.
No. Right. So bottom line is, I'll summarize it. There are two types of cholesteatomas. One's congenital, one's acquired. Congenital cholesteatomas are typically pearly white masses that arise behind the tympanic membrane. They are not associated with children that have had recurrent middle ear infections because, as you mentioned, they are essentially epidermoids. They are a malformation of the single cell germ layer that happen to arise in the middle ear cavity, and they're typically in kids. Got it? Okay. Now, more commonly, that what you'll see are these acquired cholesteatomas. Okay, so how do acquired cholesteatomas happen? Anybody know about these? Tell me what you know, and then I'll stop. Anybody want to take a guess?
They're keratin?
It's like, yeah.
Go ahead. Anybody?
There's inward pouching of pars placida into the Prusak space. Then there's secondary to recurrent infection, and that's where the keratin debris deposits and converts into cholesteatoma.
Okay, perfect. That's exactly right. Those are the basics. So what I'm going to do is give you a little bit of a primer on acquired cholesteatomas and tell you how this is going to help you for your boards, okay? So what acquired cholesteatomas are is essentially a buildup, like you say, of keratin. Now, where does this keratin come from? What's the most active organ in your body? Skin. Okay, where do you have skin in your ear? It's on the surface of your external auditory canal, right? So whether you want to admit it or not, on your skin you have constant turnover of dead skin. It's kind of gnarly to think about, but that's just the way life is, right? So what ends up happening is that you have this opening right here that runs from the back of your nasopharynx to your middle ear cavity. What's the name of this opening right here? Eustachian tube. So normally, this eustachian tube is open. So the eustachian tube functions normally. When you have this communication from the back of your pharynx all the way going to your middle ear cavity, what ends up happening is that you have positive pressure right here. And if you have this desquamation of the skin along your ear cavity, all this stuff can kind of head outwards like this. Fair enough? That's normal, right? Now, what happens if all of a sudden your eustachian tube doesn't work? It's called eustachian tube dysfunction. The communication between the back of your throat and your middle ear cavity becomes obstructed. Now, instead of having these positive pressures go in and sort of outwardly push your tympanic membrane, everything gets reversed and the pressures go like this. So what would that do to the tympanic membrane?
Atelectasis.
What's that?
It collapses. Atelectasis, right?
It would have atelecta. What specific part of the tympanic membrane?
Flaccida.
Flaccida. So what are the two parts of the tympanic membrane?
Tensa flaccida.
Where's the tensor located and where's the flaccida located?
Flaccida up, tensa down.
Exactly right. So when we look at the tympanic membrane, the pars flaccida is essentially located up here, and the pars tensa is down here. So if you have occlusion of your eustachian tube, what ends up happening is that instead of the vectors going like this, the vectors end up going like this. It becomes negative. So if you have the pressure going this way, all of a sudden, this part of the tympanic membrane gets pulled up. And what do we call this inpouching of the pars flaccida? Do you know what that's called, fellows? That's a retraction pocket. Okay. So the first part of this is that these negative pressures end up pulling up this little part of pars flaccida. Now remember I talked about that skin that's supposed to extend out? What ends up happening to that skin if it's getting sucked in? That skin ends up accumulating right here in that retraction pocket. And if that skin gets big and big and bigger enough, what ends up happening? This is where you end up having cholesteatoma. And what do you call this space that's located right here where that arrow is? That's the famous Prusak space. Has everyone heard of Prusak space? So Prusak space was actually named after Alexander Prusak, who was actually a Russian otologist. You can see it right here. But that's how an acquired cholesteatoma occurs. So this is due to chronic eustachian tube dysfunction. It ends up happening where this negative pressure, you get a buildup of this keratin, eventually it gets big enough, and this is what we refer to as an attic cholesteatoma. So this is an example, again, schematic illustration of a retraction pocket. This is the coronal reef format. You see the little retraction pocket right here? Over time, it gets bigger and bigger, and then eventually, what has it done to the ossicles right here? It's what? It's eroded it. So over time, this cholesteatoma. So what's the definition of a cholesteatoma? How we make the diagnosis of a cholesteatoma is a focal soft tissue mass that's associated with what? Bone erosion. And what's more likely, what bone is more likely to get eroded? Wait a minute. The ossicles or the scutum? Wrong. It's the ossicles. So, it's one of these things, and I'll tell you how this got into the mythology of this, okay? The most common bone to get eroded in the middle ear cavity from a cholesteatoma is the ossicle, and specifically it's the long process of the incus. Now you're saying, no, everyone talks about the scutum. Okay, you know how the scutum started? And I can say this, all right? The scutum started because, believe it or not, we have not had temporal bone CTs for the last 50 years. In the old days, when I was your age, I trained on something called conventional tomography. Have you ever seen conventional tomography? Probably not. Conventional tomography is where we took an X-ray and we kind of rotated it. And we would do the rotation and something was right in the middle. And that middle happened to be sometimes parts of the temporal bone, because we would do conventional tomography of the temporal bone. We couldn't see the ossicles that well. But the most reliable structure that we saw on conventional tomography was the scutum. So as a result, when we would say, does the patient have a cholesteatoma? We would always focus on the scutum because that was the most reliable bone. So that was always 100%, that's how we look at it. Then we switched it over to temporal bone CTs. And we see erosion of the long process of the incus and the stapes much more common than we see scutum erosion. So that's how everyone talks about the scutum, but that is one of the last bones that I see eroded. So just as an FYI. There's another type of cholesteatoma. And this is what we refer to, again, it's an acquired cholesteatoma. But for the fellows, this is what we call a pars tensa cholesteatoma. So what I showed before was a cholesteatoma that was involving the attic. And this was due to the retraction pocket theory. A pars tensa cholesteatoma is where, look at this tympanic membrane. See how sclerotic it is? See how dense it is? You can actually have small little perforations. So again, if you have this negative pressure, instead of these keratin going through here, if the tympanic membrane is perforated, it can seep its way through, and now you have a focal soft tissue mass, not in the epitympanum, but it's actually in the mesotympanum. And just to emphasize what I just said, notice how this mass is located in what part of the middle ear cavity? Mesotympanum. And how do we know that this is a cholesteatoma? Because how many dots should we see at this level?
2 dots.
And how many dots do we see? 1. Exactly. So we have a focal soft tissue mass associated with ossicular erosion, so we make the diagnosis of a cholesteatoma. Now, just to emphasize what I said, is that this is cholesteatoma, right? Where's the scutum on this image? It's way over here. It's not even close to that little puppy there. So back in the days of conventional tomography, we really couldn't make the diagnosis of cholesteatoma reliably because we were looking for the scutum. But on the other hand, when you do have these middle ear cavity cholesteatomas, that's why we look for erosion of the ossicle. That makes sense to everyone? And then the last thing that we'll talk about, again, for the temporal bone, is everyone's heard of glomus tympanicums, right? So actually, I need to update that slide. We don't call them glomus tumors anymore. We call them paraganglioma. So it should be paraganglioma tympanicum. So sorry about that. If one of my head and neck colleagues saw this, they would chastise me, okay? But anyway, so now they're called paraganglioma tympanicums. So the thing about what you should remember about these are also focal soft tissue masses, that they arise in the middle ear, but they hug, the classic ones hug this part of the cochlea. And what do we call this prominence of the cochlea right here? Take a wild guess.
Promontory.
Cochlear promontory, exactly right. So you have this soft tissue mass that's arising from the cochlear promontory. Now, why do these arise from the cochlear promontory? Because we have a nerve that runs right along the surface of the promontory. And what's the name of that nerve? If you can read, you'll get it right. Jacobson's nerve. And for you guys that are going to be taking your boards, Jacobson's nerve is a branch of 9 And for the fellows, there's another nerve that is named. That is not Jacobson's nerve, but there's another nerve that's associated with 10 that runs in the middle ear cavity. The fellows know that? Starts with an A. A-R.
Arnold's?
Yes, Arnold's nerve, exactly right. So Jacobson's nerve is 9. For the fellows, Arnold's nerve is 10. So these patients typically present with pulsatile tinnitus, and the way you make the diagnosis is a focal soft tissue mass along the cochlear promontory, no ossicular erosion. Now for the fellows again, anytime that you see one of these, and it's located in the middle ear cavity, that's a glomus tympanicum or paraganglioma tympanicum. But just realize is that sometimes these things can erode the bone. And so I don't think I've got an example of this, but just realize that if you have a glomus jugular tympanicum, these can sometimes erode the bone and be contiguous with the jugular bone. Now, why is that important? Anybody? Fellows or residents?
To be able to separate it right from like an aberrant IAC and, because you don't want to biopsy it and have it bleed everywhere.
So yes, so you want to make sure so I think I asked the bad question. So yeah, you want to make sure it's not an aberrant internal auditory canal. But let me ask you another question is that if you're a surgeon and you see this nice little 4 millimeter lesion sitting along the cochlear promontory, it's like, you ever been hungry on a beautiful day and you see an apple? What do you want to do with that apple? You just want to pick it, right? Pick it right off, right? So the surgeon sees this nice little 4 millimeter lesion that's located in the middle ear cavity. They can stick their little forceps right here and just pick it right off and they're done. It's like picking an apple, right? But on the other hand, what sometimes happens is that they'll see the apple, they think it's an apple, but in actuality, this is all continuous. It's eroding the bone and extending into the jugular bone. So if they end up trying to go intraorally, A-U-R-L, not O-R-A-L-L-Y, but A-U-R-A-L-L-Y, intraorally, and they wanted to pick this off, and it turns out this was contiguous here, they're going to have a bloody mess. And sometimes just by looking at this, they can't tell between this and they can't tell between this. So for the fellows, just anytime that you see something like this, make sure that you look at the bone to make sure the bone's not permeated, because your surgeons will love you for that, for keeping them out of trouble. All right, any questions on that? All right, guys, that's it. Thanks a lot. See you in a few months then.